Justin, clip 1.
Okay, we're just going to record some audio visual. Are these lights in the way?
Nope.
Put this up.
Oh, you can put up a little bit there.
Okay.
They're fine.
All right. So I'd like to spend a few minutes just talking about the preparation for airway management for any patient who I'm preparing to either sedate or mask ventilate or intubate or extubate. I always prepare the same setup to make sure that I'm prepared for anything that could possibly come my way. Different people have different acronyms that they use to remember all of the equipment that's necessary. I like SOAP-IM, but you may have a different one. I think the most important thing is that you do it exactly the same way every time as a form of a checklist. So in my acronym of SOAP-IM, the S stands for suction. That means not only having suction, but also checking it, making sure that it's strong enough that if the patient has an emesis event, I'm able to use the suction effectively. The O is for oxygen, and in this case, I have an anesthesia machine, so I'm able to check my pipeline oxygen coming from the wall, as well as my O2 tank on the back of the machine, which is at 2,000 psi, which is an almost full tank. If I did not have an anesthesia machine, I would still want to check an oxygen tank and make sure that I was not going to run out of oxygen. A is for airway equipment. So for this patient that I'm about to put to sleep, I'm planning on intubating, so I have a laryngoscope and I check the bulb to make sure that the bulb is working, the battery's not dead, the contact between the blade and the bulb is good, because these things can all affect the performance of the laryngoscope. I also have an endotracheal tube, and my preparation for the endotracheal tube is testing the cuff of the balloon if it's a cuffed tube. So you'll see here that there is a syringe here, and not only do I inflate the cuff, but I actually disconnect the syringe and make sure that the valve here on the end of the pilot balloon is able to hold a seal. When you do that with the syringe still attached, you may miss a leaky valve as a cause of the cuff problem. In addition to the tube that I'm planning on using, I also have one size smaller, so that in case I have difficulty passing this tube, I'm ready. And you'll notice that both of these tubes are also pre-styletted and ready to go with the stylet exactly as I would like it to be for intubation. In addition to that, I have some airway adjuncts. So I have an oral airway that I can insert if I have any difficulty mask ventilating the patient. I have the mask that I believe is the appropriate size mask, and also in the drawer I have additional sizes of masks if I have any difficulty or if I need an extra mask. And I have a tongue depressor that I can use for inserting the oral airway if necessary. All of that stuff is important, and it's good to have it available. Even if you're not planning on intubating, it's important to know where your airway equipment is in case of intubation. The final thing is that I want to be able to, I want to make sure that I have the ability to deliver positive pressure ventilation. And that can be a lot of different things. In this case, I'm actually going to use this anesthesia circuit. So I'll be hooking the mask directly to this anesthesia circuit, which can serve as both a bag mask type device and also a ventilator. But for another setting, I may choose one of these other devices, which you probably have seen before. I want to just briefly go over these two devices and explain the differences and the similarities between them. First of all, the same mask will fit onto both of them. This is referred to as a self-inflating bag, and you'll notice that although it's not attached to anything, it still works, and you actually can ventilate a patient with no oxygen source if you needed to. So this is a really important tool for in the field. If you're transporting a patient and there's a risk of needing positive pressure in an elevator and your oxygen tank might run out, I would never transport a patient without one of these nearby. And these are readily available on the walls of the hospital rooms. On the other hand, this is what is commonly referred to as a flow inflating bag, or you'll hear people call it an anesthesia bag. That has to do with the soft, flexible bag which matches this part on the anesthesia machine. This is actually a much better bag for giving CPAP and for assisting ventilation in somebody who's breathing on their own, but you'll notice that it's completely useless without an oxygen source. And so in order for this to be effective, I have to actually hook this into a wall oxygen supply and turn on the flow. And then if I just occlude here for a minute, you'll see that there's a valve here. This bag will fill up, and by adjusting this valve, I'm able to give various levels of CPAP. I'm able to open it all the way and provide 100% oxygen for the spontaneously breathing patient. I'm able to close it a little bit more and take over ventilations completely and use it as a positive pressure device. So it gives me a lot more flexibility, which is why we like it and why it's called an anesthesia bag. But the downside is you have to have enough fresh gas flow to have the bag be functional, and also there is a risk of rebreathing. So if your oxygen flow is too low, the patient will rebreathe the air that's in this circuit and develop elevated carbon dioxide levels despite their chest moving. The other things that I like to set up, so that's the A, so we've done suction, oxygen, airway. The P is also very important. P is for both personnel and pharmacy. Very important to think out loud and make sure everyone in the room is aware of what the roles are going to be and what the drugs are that you're planning on using. And in this case, if you look back here behind me, you'll see that we have both induction drugs and paralytic medications, as well as some emergency medications readily available in case of any unexpected events. Having all of that set out and discussing it with your team before you start a sedation is very important and saves a lot of trouble if there are any issues afterwards. The I, which comes next in my mnemonic, is for IV fluids or IV access. And in this case, we're about to bring a patient into the operating room who does not have any IV access. So I include in that the ability to start an IV. So on the back table there, I have all the necessary equipment for starting an IV. In addition, I have an IV set up here that I've de-aired all the bubbles from the line, and I'm ready to hook this up as soon as we start an IV. For other patients, it also might mean just verifying that the IV is functioning. It's really not good to start a sedation, be halfway through an induction for intubation, or even in the middle of an extubation, and then you find out that the patient needs a drug to, say, be re-intubated, and that's the moment when you find out that their IV is not working. So while the patient is stable, when you have the time, is the time to figure out how to keep them stable, and how to figure out that the IV is working, and secure another IV if necessary in order to have stable access. In the truly unstable patient, you may also need to place an intraosseous needle, which I have readily available in my cart as well, and which are also on all the code cards throughout the hospital. Very important to make sure that you have access before giving any medications to the patients. Finally, the M of my mnemonic is for SOAP IM is for monitors. So there are a few really important monitors that we always want to have available whenever we're doing any kind of sedation or anesthesia. That includes the standard monitors like EKG, pulse oximetry, and blood pressure. My preference is never to have the blood pressure cuff on the same extremity as the pulse oximeter, because I don't like being in the middle of a sedation and losing my pulse ox when the cuff goes up. But I do like the cuff to be cycling at least every 3 to 5 minutes so that I'm able to follow the patient's blood pressure throughout. The other thing that's very important is end-tidal CO2. And on this machine, end-tidal CO2 is built in as a tracing up here. That's because it's sampled directly through our breathing circuit and put into the machine. But you may have a color-changing CO2 device that changes from purple to yellow, or you may have a handheld CO2 device, depending on where you work in the hospital. Those devices are critical because if the patient is not ventilating well, if the breathing tube is in the wrong place, or if the patient becomes apneic from an obstructed airway, it will take minutes for their oxygen saturation to fall. And Chest rise also may still be present. So in the sedated patient with an obstructed airway, they will normally have more chest movement than if they were breathing with an open airway. And so it can be very falsely reassuring to see chest movement and see an oxygen saturation of 99 or 100%. The presence of end-tidal CO2, as well as listening for breath sounds, is really the definitive gold standard for air moving in the chest. So that is my setup, and while it takes a few minutes to talk you through it, hopefully you get the sense that it actually is not a lot to do. It takes, in a real life setting, it takes about 20 seconds for me to quickly run through this checklist in my head, and I can assure you that there has never yet been a patient whose sedation or intubation or extubation was so emergent that I would not rather have spent 20 seconds preparing for all the right equipment in case of anything unexpected happening. So I encourage you to verify all your equipment, make sure you have the right setup before you do any airway management. Thank you.